Good morning and welcome to AARP Ohio's virtual conversation with Jackie DeGenova, Ohio's Long-Term Care Ombudsman. I am Kelsey Bergfeld, Associate State Director of Advocacy and Outreach here at AARP. Thank you so much for joining us today. This webinar is being recorded and will be available to revisit at youtube.com/@AARP Ohio. There will be time at the end of this presentation to ask questions. AARP is the nation's largest nonprofit, nonpartisan organization dedicated to empowering Americans 50 and older to choose how they live as they age. With a nationwide presence, AARP strengthens communities and advocates for what matters most to the more than 100 million Americans 50 plus in their families. That's health, financial security, and personal fulfillment. AARP has been a strong voice for consumers in nursing homes and their family caregivers, highlighting the industry's need to improve quality and accountability. For free resources and supports on family caregiving, please visit aarp.org/ohcaregivers. We'll also share a link to that with a QR code at the end of today's presentation. We have been proud to work alongside the State Long-Term Care Ombudsman to advance policies that ensure nursing home residents and their families are empowered to assert their rights to dignity, autonomy, privacy, and respect, and have the support to pursue options to address any violations. All states and the District of Columbia have a long-term care state ombudsman who works to resolve problems related to the health, safety, welfare, and rights of individuals who live in long-term care facilities such as nursing homes, assisted living facilities, and other residential care communities. Today's webinar will focus on Ohio's Long-Term Care Ombudsman Program. If you are joining us from outside of Ohio, or if you have loved ones in nursing facilities in other states, this presentation will help you learn how the Ombudsman Program in your state can help support and advocate for yourself or your loved one in a long-term care facility. I'm pleased today to welcome Ohio State Long-Term Care Ombudsman, Jackie DeGenova. Ms. DeGenova, an attorney, joined the Department of Aging in Ohio in November of 2021 as the Chief of the Division for Community Living and stepped into the role as State Ombudsman in November of 2022. She leads the state office and 12 regional programs of the State Long-Term Care Ombudsman Office, including programmatic planning, quality assurance, and budget and fiscal monitoring and systems advocacy. If you have questions of our guests during the presentation, please type them into the Q&A function at any time. Again, we hope to have time at the end to get to those questions. And when you are ready, Jackie, you are welcome to begin. You should have control of those slides.
Thank you very much, Kelsey. I am very pleased to be a part of this education webinar series, kicking it off, and so pleased that so many of you could join the presentation. Hope to leave a little bit of time at the end for some Q&A. So if you think of things throughout the presentation, please do add your questions. It helps you learn, it helps us learn, and get our messaging out to you all. Okay, so let's see, next slide. Looks like I am having a little bit of trouble moving the slides along. There we go. Thank you. So today's topics will go over an overview of our Ombudsman program and the core services, and also want to talk a little bit about the Nursing Home Quality and Accountability Task Force that was begun last year with an executive order by the governor. And we'll talk a little bit about the work we're doing in the Ombudsman's office to implement those changes and work with other groups in the work streams to improve the quality in Ohio's nursing homes. And then we'll save a little bit of time for some question and answer. So the Long-Term Care Ombudsman Program, we advocate for excellence in long-term services and supports wherever the consumers live. So this can be services that consumers have at home. Generally, we work within nursing facilities, assisted living facilities, and residential care facilities of a Class 2, formerly known as group homes, those with that are recovering from addiction or have some mental health issues that live in group homes. So we advocate for excellence, receiving all those services and wherever those consumers might live. So a little bit about the Office of the State Long-Term Care Ombudsman. It is headed under the Older Americans Act and Ohio law. It is to be headed by a state ombudsman. It is a distinct and separately identified program, meaning that we sit within the State Unit on Aging, within the Ohio Department of Aging, but we have a separate authority to speak with the media or to speak with our legislators. We can do advocacy of all sorts, whether it be, with on an individual level or on a larger scale for sort of nationwide advocacy, commenting on rules, commenting on the staffing rule that the Center for Medicaid and Medicare is working on it with the federal government. So we have a lot of different advocacy efforts. Overall, the state office is responsible for ensuring that all of our program requirements are fulfilled. We will go through a little bit of those. We ensure that all of our representatives, ombudsman representatives, are fulfilling their duties according to what the law allows and requires as our responsibility. And the state office has the unique authority of designating who can be representatives and which local sponsor agencies are designated as ombudsman entities. So we'll talk a little bit more about that. There we go. So the ombudsman office locations, we talked a little bit about the office of the long-term care ombudsman. We have 9 state staff in the Rhodes Tower in Columbus. And that's myself and a deputy long-term care ombudsman. We have a quality assurance manager, and those that look through the cases and complaints and do our federal reporting. We have a volunteer coordinator, and we also have some transition advocates for when a nursing home may close. And so we assist the regions in transferring all those residents, might be 100 residents or something like that need to be transferred to other facilities. So we have those who specialize in that area. And we also have those that help us draft comments for policy and work on those advocacy measures on a larger scale. So that makes up the 9 staff at the state office. And we also run the programmatic functions for the regional programs. You can see on the map here that there are 12 regional programs. Some of those reside with the area agencies on aging, about 5 of them. So not all of our programs are sponsored by AAAs. They may be sponsored, for example, by Pro Seniors down in Cincinnati or Direction Home of Northeastern Ohio. So we have sponsoring entities that will hire the representatives, the ombudsman representatives. We do the certification, we train them, and they are representatives of our program, as well as being hosted by these sponsor agencies. So we have about 110 staff for the state of Ohio. That includes program directors, 12 program directors in the regions, a volunteer coordinator, and certified ombudsman specialist. Those are the folks that are in the field, so to speak. They visit the nursing homes. They are doing community activities. We also have 156 volunteers. They are called Ombudsman Associates. And we are looking always for more volunteers. Pre-COVID, the volunteer number was about 250. Understandably, volunteers did not want to go into nursing facilities or assisted living facilities during COVID and during lockdown. So we're looking to make sure that we can increase that number. So you all can help us with that. A little bit about our specialist certification training. So there are 10 hours of some pre-work, case study, look at the laws. We do 30 hours of classroom training, like you would for any certificate or degree, and then 60 hours of that field work and experiential learning. That's completed by the regions. There'll be a mentor or shadowing experience, a little bit like an apprenticeship for 60 hours with a certified ombudsman already to make sure that our new trainees understand, how to talk to our residents, to begin to have a relationship with the administrators or the director of nursing in a facility or in assisted living. So it really is like any job. The more you practice, the more you learn and the better you become after, several years. So we do take exams to become ombudsman specialists and volunteers as well. So you need a deployment exam to complete the experiential field learning. And then after your 60 hours of that learning, you take an ombudsman certification exam. So the representatives, again, of the office are regional staff or volunteers, so they can be employees or volunteers. They, again, must be designated by the state ombudsman, and they have to follow a certain code of ethics, make sure they know the laws, and be responsible, generally be responsible for carrying out all the duties of the program, including, the complaint handling and making sure they're documenting things appropriately. We have a lot of documentation because this is a federal nationwide program, as Kelsey suggested earlier when she was introducing me, that every state and even our territories, Guam and Puerto Rico, have programs. And so CMS and the Community for Administration of Community Living wants to know how the program is running generally nationwide. So we have a lot of documentation and reporting at a federal level as well as a state level. So let's talk a little bit about the program authority without getting too deep of a dive. Our authority and responsibilities come from the Older Americans Act of 1965. It started as a pilot program. Actually, as amended during the Nixon administration, it started as a pilot program. And then it was determined at a federal level that every state should have an ombudsman, a leader for the state to manage things and the programs and responsibilities throughout every state so that residents in these care facilities would have an advocate. Oftentimes, many of you may know this already, but oftentimes when folks are saying, well, what do ombudsmen do? I like to suggest that it is similar to, everybody has heard of a crime victim advocate. So you have your prosecution, your defense, and then you have that person who is specifically designated to speak for the victims of a crime or speak their voice. And while we don't look at residents in any way, shape, or form as victims, it does help us understand that it's a separate role from the regulators who look at nursing homes or those that run the facility, right? Or those that inspect it, or even the oversight by CMS or something like that. So it is a very unique role. And we get our authority through the federal Older Americans Act, and then it is also within the revised code, and we have our rules as part of the administrative code. So there's those citations. If any of you who aren't lawyers might be interested in that, you have the citations there. So again, it is a unique authority and responsibility. We have very strict confidentiality provisions. We need to have consent by the client in order to investigate a complaint, in order to share any of their medical records or information or any of their concerns. And that may even mean with another family member. That may mean with anyone at the facility. So there really is choice by the client, the resident, as to what they want us to share or whether or not they want our assistance in complaint handling. It is very strict, and that is to ensure that there is trust built up and then that the resident may know and have an idea that we will not share anything unless there is consent for that or a court order. We do have specific conflict of interest provisions that have to be remedied. For instance, none of our representatives can have an ownership interest in a nursing facility or have worked in a nursing facility for a few years. We think it is a conflict of interest to be the ombudsman assigned to a facility if you have a relative that resides in that facility, right? Those personal conflicts of interest that may impair our judgment, may influence the way we look at things as sort of from a neutral, objective standpoint. So we have a rigorous conflict of interest provisions that we must comply with. And we also have the authority to pursue administrative, legal, or other remedies on behalf of the resident. We can ensure they have appropriate powers of attorney if need be, or speak with their guardian, or assist them in a hearing, let's say on a discharge. We have authority to make sure that residents we are also protected from willful interference with us doing our jobs. We have the right to be in these facilities. You have the right to look at medical records, to look at the nursing facility records. We have the right to legal counsel that is free of conflict. We also are authorized as ombudsman representatives to have regular, timely, private, and unimpeded access to residents and to the residents' records. That's really what the heart of ombudsmen do, is that we have the right to that advocacy. We have the right to talk and see and observe residents and what's going on in a nursing facility, assisted living facility, or another type of home that someone is getting congregate care. So, next slide. Seem to be timing out a little bit. Let's see if there we go. So the ombudsman role, again, is to empower residents with information, tell them what their rights are, make sure that they are empowering themselves with their rights to participate and rights for choice. Our approach is, our whole philosophy is one to implement the residents' rights. Not as a caretaker, not as a direct line caretaker, not as the compliance or regulatory person, not to tell them what the best way, should they eat that piece of cake or shouldn't they, but it really is a philosophy of implementing the rights of the resident and their choice and their right to self-determination. We'll go over a bit of our core services that'll give you a better idea of things we do day to day. And our focus, again, is on resident satisfaction of resident rights, not that regulatory compliance. Our goal is to meet and to handle the complaint outcome to the satisfaction of the resident. There we go. So our residents' rights categories generally are for information, self-determination and choice, participation, and privacy. So we've talked a little bit about these. We'll go into a bit more detail. I think the important thing to remember is that, we all enjoy the rights to have information, to talk to our bank, to understand how our bills are being paid or why we're being charged a late fee. We all have the right to vote. We all have the right to make determinations about what time we get up in the morning and what we have for breakfast and what visitors we can see. We all have the right to participate in our treatment or the activities we do in a day. We all have the right to have a private phone conversation. So we approach, and our philosophy again is always to remind, sometimes it's family, sometimes it's nursing home staff, sometimes it's in webinars, that we don't lose all of these rights categories because we may be in a setting where we're dependent upon someone else for our daily care. Because we have a nursing home level of care, we may not be able to get out of bed every day freely, or we may need assistance with the shower, but we still have all of these rights to do so. And that's what ombudsmen do, is we ensure that the residents have these rights and are empowered to voice their rights. So our client's view, again, of quality is similar to where the residents' rights are laid out in the statute. Kind treatment by staff, a respect for their dignity, and to have, be spoken to in a manner that is appropriate, to have opportunities for choice and input into their care. And again, to have a private conversation with their loved ones, or have a medical exam in private. These are all things that we know in our daily lives, and we want to ensure that are being kept and remedied if need be for residents in congregate care. So let's talk a little bit about these rights. Choice and self-determination, I think, is something that each of us would say is paramount on our rights to have a dignified existence. Accommodation of individual needs and my preferences. I may want to get up at 10 o'clock in the morning because I'm in a residential care facility. It doesn't mean that everyone has to get up at 8 o'clock in the morning. I have the right to sleep in. I have the right to determine what I'll have for breakfast. I have the right to determine, what my activities, what my schedule will be, make sure that my activities meet my interest, to have a health assessment and to participate in those plans of care. I have the right to voice my complaints. So even though I'm at a level of care and I'm dependent on someone else, it doesn't mean that I lose the right to have a choice and have my own self-determination. I have the right to understand what's happening with my billing, what charges are being made, to understand the services that are provided and what that might cost. These are, again, are things that we all know in our daily lives. And so because we may be dependent on someone else to explain these things to us, it doesn't mean that we don't still have the right to that information. So ombudsmen help ensure that residents can understand this and that they have a choice in maybe denying a service or what kind of treatment they may want, something like that. So again, it's part of this decisional autonomy, informed decision-making, alternatives and consequences. Do they understand they may be healthy enough? They may be in a nursing facility for rehab. Are they healthy enough to transfer to an assisted living, or to go back home? Maybe they want to go home, but they're not quite ready from a physical standpoint. So they still may have the decision-making authority and autonomy to make those decisions. Do they understand the alternatives or the consequences there? That's part of what we try to do as well. They have a right in every resident, just like we do, for our planning, for our care, for the types of treatment, how often we may get a shower, who our visitors are. They have a right to participate in resident and family groups. We'll talk a little bit more about that. What activities or no activities, right? If I want to spend the day watching TV or reading in my room, we all love those snowy weekends, right? So it's no different just because we're in a congregate setting or an assisted living setting, just making sure we can participate in those decisions that we all do. They also have the right to participate in the annual surveys that the Ohio Department of Aging does. We have a survey where we work with a consultant group, and they go out and personally interview about 35,000 residents in nursing home and assisted living care facilities to see, how they're enjoying or not enjoying their care. What do they think of the food? Do they get enough showers? Is the staff kind to them? Do they have a good understanding of the care plans that they have? So these are really vital pieces of information that we hope to impart not only to the Ombudsman's office, but as a launch pad for different advocacy and for quality measures in nursing homes. So again, residents have the right to participate in a survey and talk with administration to understand how decisions are being made, or how the diets are coming together, to speak with the director of nursing, something like that. So again, privacy is huge for all of us, right? We have privacy in our treatment, privacy on the telephone, the visitors that we all want to have, our mail, our records, to meet separately with your spouse in private or someone who's not your spouse. Often folks fall in love in their later years in nursing facilities and assisted living facilities. So there's a right to privacy there as well. Also have a right to private conversations with ombudsman. So ombudsman core services, we've talked about the rights for individuals, and our core services really speak to how we can ensure that. How can we use our authority to investigate and help resolve complaints that folks have, right? If someone doesn't understand why their treatment has changed, or, do they have the right to know that they may be getting a new roommate? Or are call lights being answered in a timely way? Can they reach their call light? So these are the types of complaints that we get, or we may see that in an advocacy visit that we do. As ombudsman, we try to reach the facilities in Ohio at least quarterly. So again, going back to the map that we had, there's about 109, 110 ombudsmen who are in the field, visiting facilities, and there are roughly 2,600 different types of facilities, and about 125,000 residents in those facilities. So we don't have near enough ombudsmen to be in a facility every week, and speak to every person there. But we can go in and do an advocacy visit and use our own observations to see, does it look safe and clean? Are there things cluttering the hall? Do we have residents wandering around, or is no one coming out of their room? How does it smell? How does it look? Does staff seem attentive? We can share information with those residents, letting them know about ombudsman and what we can do to advocate. We also educate providers about residents' rights and good care practices. There's a lot of staffing changes. We've all heard about shortages, not only with nurses and nursing staff, but folks still learning their jobs. So we work with providers as well. The providers being in the nursing facilities or assisted living facilities on, best practices, good care practices, what the resident has a right to, and things like that. We also assist in our core service with resident council. These are meetings where the residents can set up what they call a council. Anyone can participate. Ombudsmen have the right to attend and present at a resident council meeting. So again, it is this right on the residents' behalf to meet together to discuss, activities or a change in the meal planning, or how often and what types of activities, or shower schedules, or whether or not they like the care that they get from a certain person in a facility. So anyone that isn't a resident must be invited to attend a resident council meeting. So it's not a nursing home person who can be in the facility, not an ombudsman. We have to be invited to attend. And we do this quite often. We help to set up a resident council. Is there a person in the facility who wants to act as the resident council president, who has the voice already to speak with the administration? Similar with the family council, those family members and loved ones who visit the residents and their loved ones in facilities often can do a lot of things as a council with outreach, and not only developing the council, but working toward making changes, or just speaking, having a really good relationship with the administration. So we work on these things as well as a core service. We do community education like we are today. We can work with social workers or hospital discharge planners. We work a lot with adult protective services. We meet with law enforcement, emergency management, county fire chiefs and things like that, right? So We have a lot of community education and a lot of folks in that long-term care network that we work with a lot, including AARP. I've been privileged to sit with Holly Holtzen on the nursing home task force, which we'll talk about in a little bit. So we also assist seeking legal, administrative, or other remedies. Does a resident need a guardian? Is their guardian using the least restrictive means, if they have one, right? To still have the autonomy and decision making? Or is there a right to a hearing if the resident is being discharged from a facility? They have rights to a hearing. Is this one of those situations where the resident may not want to leave, may not understand why the facility is asking them to leave? Conversely, they may want to discharge, and they need to understand what their rights are there, and we assist as an advocate in those legal proceedings as well. So other examples of individual advocacy, we've talked a little bit about a daily shower, addressing needs to be assisted with eating slowly, helping a resident fight a discharge. Sometimes it's the advocacy to make a bad choice or a choice that I wouldn't agree with, right? If we have someone who's a diabetic, might they still have the chance to have a piece of cake? Well, their doctor would advise against it. My doctor advises against it, but I like to eat cake anyway. So what might be the right scenario to advocate for them in that scenario? We do systems advocacy. We talked a little bit about rules at a federal level, Department of Health rules, Veteran Services rules, mental health and addiction services. Where might we be able to impart some advocacy in policies there? So we can do advocacy again within the facility. Let's talk to the administration about the numerous cold food complaints, or, no one likes the mashed potatoes. Is there something we can do with that? Is there, what is the root cause? Is there, have you changed vendors for who is providing you with some of the meals? So there are just many other types of issues for systems advocacy. We talked about unanswered call lights, or making sure that every resident has a phone in their room, or can the call lights be reached, right? Is every bed close enough to the tray where residents can feed themselves and hit the call light, something like that. Outside of the facility, again, we work to change things like discharge laws. There was a recent addition to the discharge laws that states in the law now that wherever the resident will be discharged to must be able to handle that level of care, must be able to meet the needs of that individual resident. So the current facility must look to the next facility and not only provide a 30-day notice to the resident with all of the information that's entailed, but take a look at this next facility and say, yes, they accept their insurance payer source. Yes, they can meet their level of care. And talk to the resident, and we go in and advocate for the resident for these instances of discharge. Another instance may be working to require the facilities to have a generator. What happens if the power goes out? So can we get the laws changed to make this a requirement? Esther's law was a law that a certain individual in Ohio who had lost his mother advocated for, and we were also advocating for that. And now we help to ensure that if a resident wants to have a camera in their room, that they are free to do so, that the administration understands that that's now state law. So that's part of our advocacy as well. Ombudsman complaint handling protocol. Again, we can do an intake. We'll get a complaint. We learn, what is the scenario here? Is it a discharge? Is it a question with the social worker? Is it, someone not having their call light answered, or they feel a certain person at the facility, doesn't like them, or they have a fear of retaliation? So what is what is the issue? We will have that intake meeting in person. The first thing we do is explain what our role is as an advocate and that it is confidential. Our conversation is confidential. We won't share it with the nursing facility. We won't share it with your sister if you don't want us to. We won't share it with your, other caretaker. We do need to get consent and to handle a complaint. Sometimes residents do not want that. But we do need it. We also need the consent if there is a guardian or a power of attorney. So our ombudsman representatives need to be aware of those types of laws and what they mean and make sure they understand that. Then we can have an investigation and we look for what is the root cause. Are the call lights not being answered because it's during a shift change or something like that? Then we'll come up with an action plan for a resolution and have a follow-up. These are our top 10 complaints across different settings. I know that's a lot to read and understand, but we can see that discharge and eviction is one of our largest complaints, whether it be a discharge for non-payment, where there's been a change in some sort of insurance, or there's just a question as to it. And does the resident understand that? Does the facility understand the resident's rights to have all of the information in a discharge notice? Those notices are copied to the ombudsman office. We can review them. We get hundreds of them, every month. So those can be a challenge, and it is the top number one complaint. Personal hygiene, their symptoms unattended, they're not being turned, in their beds, or they're sometimes, not always, sitting in, a filthy depends, or they can't have visitors or something like that. So these are the types of complaints that we get. We receive about 10,000 complaints a year for each of these different types of facilities. We are, again, looking toward satisfaction and resolution to the client's satisfaction. So if we go in and we've changed how many days a week they get a shower, that's their satisfaction, right? Another loved one may think that person should have a shower every day or every other day. But if the client wants a shower every third day, then we respond to the client's wishes. So our complaints, about 89 or 90% of our complaints are resolved to the satisfaction of the client. Sometimes we can't resolve it. Other times there's a limitation to what we can do. We don't have a whole lot of enforcement authority, again, as a regulator, to change laws or to require that a nursing facility or assisted living facility, thing. We would work with the Department of Health on that. What we can do is advocate, negotiate, mediate, help the providers understand the resident rights in seeking a resolution. It is really all about a good working relationship with the administration as well as with the residents. So again, just a little more about ombudsman and our role and what we call staying in our lane. We advocate for the resident. We can assist in getting them help. Do they want to talk to the social worker? Do they want to talk to the director of nursing? Or can they call their physician when they want to? Are we facilitating things to, let's say they want to talk to their bank. We are not the ones who will necessarily be the person to call the bank. We may have to call in a family member or their power of attorney or a social worker, someone else who might assist them, because we are not direct care providers. It's not in our authority. We don't have any qualified immunity at the state to, provide services, to feed a person or to give them medications, or even push them down the hall in a wheelchair, because we're not the experts on what their healthcare needs are, or getting them in and out of a wheelchair. We are not going to know this about all of the 125,000 residents in these facilities. So to take those steps would be out of our scope of authority. We may call to have someone assist helping the resident out of their bed and into a wheelchair to, take part in an activity. So these are just kind of the stay in the lane and not in our lane. We are not a first responder. However, if there is an overnight closure, the power goes out, what happens to these residents? We are on the spot to assist those residents in reaching out to family members, making sure that they have their medications and their dentures and everything else that they need if they have to transfer, whether it's a short period of time or a long period of time. So this is our regional contact information. If you can see one of your regions there and you want to contact your ombudsman, and you have a particular complaint or you just want to talk about those rights, please reach out at a regional level. There are folks who are in these regions who are able to help you. We are hoping to hire a bit more a few more ombudsman representatives. But for now, take a look at this information. We'll have this back on the screen later. But again, these are our 12 regional ombudsman contacts. So let's talk just a little bit about the Nursing Home Quality Task Force. I know we're running a bit late on time, so I'll zip through these. So a little bit about why that matters and why the governor decided to sign an executive order for the Nursing Home Task Force. We already have the 6th largest population of older adults. We know that this is growing in the next decade and to continue on. And we also know that our acuities are rising. People are entering nursing facilities. Dementia is rising. Levels of health need are increasing. So this, as the population grows older as well, more people want to reside in their homes. So there's a change in the way folks want to live, maybe not in a nursing facility, but in assisted living or at their home getting other types of care. So that transition will not be an easy one. We need to build services. And so remaining in a nursing facility, looking at the best services we can provide is part of the reason why the governor wanted to start this task force with all of these different members that you can see. Again, AARP was involved to a large extent. Holly Holton was at every meeting. So you can see that it's a task force of representatives and some researchers and academics. Those advocates, those agency representatives, the associations and provider representatives that were on the task force, healthcare assistants, disability rights, lots of wonderful and dedicated folks were on this task force, headed by the directors of Department of Aging and the Department of Health. So we had many community listening sessions. You can see that we were around the state with these listening sessions. There was also a few teletown halls that AARP was kind enough to set up so that people could call in, whether they were residents or their family members, to really hear the residents' voice. Just a couple of pictures at these listening sessions and these task force meetings. They were well attended. And they were working task force sessions, right? So how will these recommendations be put forth? What is this task force going to recommend to the governor and to the state of Ohio about changes in quality or the other needed changes? How do people find a nursing home? What's the information like? So some of the recommendations for empowering residents, for example, and you can see in 3.5, one of the recommendations was to expand the staff for the long-term care ombudsman and emphasizing special attention to those residents who may be isolated. There's not a list right now of who's the isolated resident in these, 2,600 facilities? How do we begin to find out if someone might be isolated? Do they have family members who can help and visit? And do they do that often? So the other nursing home task force updates are in these work streams. One was an R3AP expansion, and that's now called a RAP team. It developed out of sort of the crisis staffing during COVID. The state and governor determined that there was a need in nursing facilities and assisted living facilities for more care and those who understood infection control, and perhaps they needed better education on infection control or how to get the vaccines to these facilities. So this RAP expansion is now about technical assistance to facilities to learn more about medication or UTIs, pressure sores. So it really is a way to collaborate with providers, with these different types of facilities so that they can have the best knowledge out there. They asked for that through the task force, and the state is going to provide that in this priority area. Surveyors, we need more of the regulators and surveyors to go out and inspect the nursing homes, make sure the sprinkler systems are working, make sure that there's no immediate jeopardy, that there's not abuse and neglect and things like that happening. The public-facing dashboard is another one. If you haven't seen the nursing home quality navigator, please do take a look for that on the Ohio Department of Aging website. If you're looking for a nursing facility, it's a great new dashboard that you can find and look for a nursing home. It will do it by region or specifically for a facility that you know of. And then the ombudsman strategy, hire and retain more ombudsman, making sure that we're investing with money into the regions. And we did a gap analysis of the resident needs. Where are there the most nursing facilities or the most group home facilities? Where is the need and where do we need to hire more ombudsman? You can just see sort of a quick picture of where the gap was on the hours in the week and what we can cover, what we can't cover. We also took a look at where sort of the highest need, these priority nursing homes that have lower performance and may need more assistance, not only from this RAP team, but ombudsman advocacy. So again, our regional plans from the task force, we were, along with hiring more ombudsman, we focused on these recommendations to look at strategic priorities. One was for isolated residents, making sure we're addressing all of the core services, getting the word out to Ohioans, like all of you, or to hospital associations that discharge from a hospital to a nursing facility, or really looking at holistic systems approaches. Again, our regional plans are on our priority areas, talking about workforce. How do we add more ombudsmen? How do we better train and recruit more volunteers who also have to be certified, have to go through continuing education? These are not your go in and hold the hand volunteers. These are working volunteers who are so dedicated. So we're looking to recruit more. Again, working with our network engagement, making sure we have quality performance and standards, and making sure we're documenting and having federal and state reports, and always empowering residents. You can see those things here as well. A little bit, this is our own checklist that we made as a plan template. Are our cases meeting these quality indicators? Do we always have consent? Are we making sure that we're reviewing the medical records? Are we trying to meet our quality assurance with our core services at every turn? And developing a more robust plan of engagement with certain key groups and speaking in community education. So that's a bit about, what our core services are. And we do have a little bit of time for questions and comments. I know that was a lot to take in, so thank you for your attention. Do we
Jackie,
have any questions?
we sure do. Jackie, that was a fantastic presentation. I know I learned
Thank
a
you.
lot And we do have some great questions from our attendees today, so I will go ahead and begin with a few. First, would love to ask, one of our attendees knows a lot of retired nurses who they think might make a good volunteer associate. Do you recruit particular populations to be volunteers?
That's such a great question. Yes, we do. You would be amazed at how many retired nurses, school teachers, those who volunteer already. They really have, to be an ombudsman, either volunteer or specialist, is very similar to nurses and even nursing home administrators and directors of nursing and things like that, people in the industry as well. You have to have that empathy and that have that mission driven that really speaks to you. So yes, we do. We are open to those. Right now, we are also recruiting. We happen to have some money very generously from our legislators. There was a House Bill 33 in the budget bill, gave the ombudsman program through the franchise fee at Medicaid to be transferred over to the ombudsman program to hire new folks and do a recruitment campaign for volunteers or specialists. So we are recruiting in every region right now. So yes, yes, and yes. Love that.
Excellent. Our next question comes from one of our AARP advocacy volunteers. Is there a legal or a fee for legal counsel working with the ombudsman in the interest of the resident?
Say that again. Is there a fee for legal
Counsel when working
working?
with the ombudsman in the interest of the resident? I think maybe, is there a fee for your services?
There's not a fee for our services. Any outside lawyer, of course, would need to be paid, or it could be something like Pro Seniors or Able or the name is escaping me now, but there are several other legal organizations through the Ohio State Bar organization that might be pro bono or
Legal aid,
legal
I
aid
think.
services.
Legal aid
Say
services.
again? Yeah,
Legal
legal
aid
aid.
services, yeah.
Yep. So there are lots of things for those seniors who need counsel. But yes, our services as an advocate are free to the resident.
Excellent, great, Jackie. A couple more questions before we
Sure.
will wind things down today. Our next question, with increased federal funding for various kinds of recovery programs, we've seen an increase in small congregate living units in residential neighborhoods. How does your office keep track of these new facilities where the residents seem to be largely transient? And are the owner operators required to register with you or elsewhere?
That's a fantastic question. Someone is really knowledgeable. It is a challenge to keep track of these new places. That responsibility rests on MHAS, Department of Mental Health and Addiction Services. We work with their office. Again, that's another one of our long-term sort of networking and engagement. So if you wanted to know whether or not they're on the radar with MHAS, yes, they do need to, it really depends on size and things like that and what the services are that they offer. So they will need to go through that application process and make sure that they are providing their ownership information. And so there is that oversight, the same as there would be with the nursing facility that applies and has oversight by the Department of Health. So I would say go to Mental Health and Addiction Services.
Excellent, thank you for that. Next question. Are residents who are evicted from one of these facilities referred to Adult Protective Services? Or are they dropped off at homeless shelters if no other placement can be located?
Sadly, to my knowledge, they are not often referred to Adult Protective Services. And sadly, we do find that there are some facilities out there that, will discharge a resident and they have no place else to go. And so it might be to a homeless shelter or to a bus stop or something. These are the types of cases that we get at the office as well, as abuse or neglect or exploitation, something like that. So there was some additions made to the law just this past year that said, I think I talked a little bit about, is that discharge transfer location a safe alternative? Can it meet the needs of this particular resident. And it's complicated to give, no, there's not a one size fits all. There are several nursing facilities administrators who, are doing their best, that are giving the 30 or 60-day notice and are working with the resident to help them have choice in where they might go. That doesn't happen in every case, and there are instances that it might be to a shelter. And we work hard to make sure that we capture that. We're supposed to get the discharge notices, so we will go in and try to advocate for that person as best we can. So sadly, that does happen.
Jackie, another question for you. What is the advocate to patient ratio for Ohio versus other states?
The advocacy education ratio?
Advocate to patient ratio.
Oh, so I don't know off the top of my head, other states, there was a study done, it's probably 15 or 20 years old now, that says that there should be one ombudsman advocate for about 2,000 residents, right? To get around to these nursing facilities and have a caseload as complaints come up. Ohio, we are so fortunate to have a really strong ombudsman program. Our legislators are great to us. We've had many different administrations that provide enough funding and enough autonomy to be advocates. Many states have, the larger states, California, Florida, Texas, have a pretty robust ombudsman program, but there are others that have, the state of Hawaii and all their islands, I think they have 2 or 3 ombudsmen. So we definitely have a stronger advocacy to resident ratio. I don't know that I could name it for every state, but we might be able to find that information for you. I can tell you that we do have a larger state staff, and with well over 100, over 100 ombudsmen, I consider myself, very lucky, and I'm very grateful for that.
That's great news, Jackie. Thank you for sharing. We have 2 questions left, and then we will wrap up.
Okay.
Both have a little bit to do with staffing in our nursing homes. The
Okay.
first question is, do you find that assisted living facilities within Ohio are short-staffed on care companions, specifically not nurses? This person notes that at a facility in Northeast Ohio, the facility where their loved one is cannot seem to hire and retain quality or qualified care companions.
I'll tell you that's a good observation. And I think it's fair to say that, care, everything from nurses to care aides to, STNAs, everyone needs, healthcare employees now. And I think that is maybe doubly true for the quick expansion of these assisted living facilities, not only in Ohio, but across the country. Understandably, people want to live in an assisted facility rather than, a more institutional, so to speak, environment. What we find in the ombudsman office is that the culture of the facility makes a huge difference, right? Even though there is a need for all sorts of health workers, we find that there is better retention if there's a great management oversight, and the corporate structure works better as a culture within that community. They care about the workers, right? It's a tough job. It is, we all talk about self-care and well-being, and that needs to be part of a corporate structure as well for employees as well as residents. And we try to assist and advocate for that as well. So we do, just anecdotally, yes, we do find that that can be it can be challenging because there is so much growth in assisted living facilities. If there is one in particular you would want the ombudsman to look into, and that, I think you said Northeastern Ohio, call into your state or local ombudsman's office, and we'll be happy to take a look at it.
Excellent. Jackie, very last question for us, again, related to staffing. Again, this attendee noticed across that there seems to be the same complaint across care settings, again, not having enough staff to do things and for quality of care. Is there a role that the public can play in supporting policy changes that would improve patient to staff ratio?
Absolutely. So right now, CMS and the federal government are looking at the staffing ratio, at the rules that are going to talk about a minimum staffing requirement. And understandably, the industry is saying, we can't hire enough staff to begin with. How can you expect us to have, a ratio of, 2 hours every day for the nurse for, per resident or something like that. It's a complicated formula, but we believe as advocates that there should be a bar, a floor, a minimum for the amount of time that each resident is taken care of every day, right? Not only with feeding or showering or, medical needs, something like that. So folks that want to play a part should either write to their legislators or go on the CMS website. And I know the public comment period is over, but I think there may be opportunities still to advocate for that type of thing. I think it's really important, as with anything, if you feel passionately, look for those ways where you can self-advocate, and particularly for those loved ones who may be at a level of care and they can't do it for themselves. So working together, hopefully we can all make that a little bit better for folks in congregate care settings.
Jackie, an excellent note to end on. Any last words for our attendees today?
Thank you for your attention, your great questions. It's really been a privilege to help me do part of my core services and educate all of you. Hopefully you can get the word out at any time, ask for a brochure, be involved in your community if you'd like to educate, and also volunteer or become an ombudsman. We are all for it. We are all for it. Thank you for your attention. And thank you, Kelsey and AARP, for letting me be a part of this series. It's been terrific.
Jackie, thank you again for your time, and thank you for the work that you do and that your office does for folks all across Ohio. It's incredibly, incredibly important. And just one last note to leave you with this morning. So AARP will, of course, continue to urge Ohio and make sure that our elected leaders know that nursing home residents and their family caregivers are centered in efforts to improve quality and accountability in our state's nursing homes. We're also working here in the state to advance policies that help support Ohio's 1.4 million family caregivers, helping care for their loved ones independently at home for as long as possible. AARP fights every day for common sense solutions to save time, money, and provide support for our family caregivers. If you are interested in a free resources or to follow along with our fight and our advocacy for family resources here in the state, you are please welcome to join the fight either through the QR code on your screen or to join via our website at www.aarp.org/OH caregiver. So that will be our one-stop shop for a lot of great resources for family caregiving and, of course, for opportunities to be involved in our advocacy here in the state. And of course, you're also welcome to email us with any follow-up questions. Again, our presentation was recorded today. It will be sent out to everyone who joined us and who registered. And again, want to thank you so much for your time this morning and for attending our virtual presentation of Leading with Care, your friend, the Ombudsman. Jackie, thank you again for your time. Thanks.
Thank you.
And have a great rest of your day. Thanks, everyone.
Thank you.